The healthcare system, payment reform in American healthcare, the latest. And the learning objectives for this lecture are to understand the history of payment reform, the sustainable growth rate, the doc fix, MACRA of 2015, advanced alternative payment methods, MIPS or merit-based incentive payment systems, and what this has to do with quality overall and how it's supposed to be an engine driving better quality of care in this country. When Medicare Part B was initiated in the 1960s, providers were paid on a fee-for-service basis. They were paid what they charged, according to what was called the customary prevailing and reasonable rate. The current method of paying physicians under Medicare, payment for service is limited to the lowest of the physician's billing charge, or the physician's customary charge, or the prevailing charge for that service in the community. And this is similar to, in your textbook, the usual, customary, and reasonable system used by private insurers. For insurance companies, usual means a fee that's usually charged for a given service by an individual physician to his private patient, that is, his own usual fee. Customary is when it's within the range of usual fees charged by physicians of similar training and experience for the same service in the same limited geographical area. And a fee is considered reasonable when it meets both of those criteria. The American Medical Association in 2013 took the position that they believe that there's no relationship between the Medicare fee schedule and what usual, customary, and reasonable fees are. So they really did not like these definitions. There were some attempts to tie reimbursement to the rate of increase in the Medicare medical price index in the 1970s, which failed. And then in 1989, in the Omnibus Budget Reduction or Reconciliation Act, the practice of assigning payment for services based on relative value units began, and then later called resource-based relative value units, or as some physicians like to refer to them, really bad relative value units, because they don't believe that they are adequate. And the relative value units measured the time, skill level of providers, and the intensity of service provided to form the basis for prospective payment, which means you let people know in advance what they will be reimbursed for each episode of care. The idea behind using these relative value units was to standardize payments for Medicare procedures using the CPT codes, or current procedural codes, used for billing. This was easier said than done, particularly when taking into account the customary and usual charges within geographical areas, as you can see here. These graphs are taken from an article for Health Affairs by Cooper and Associates. These are for 3 procedures that are reimbursed by Medicare during the years 2008 through 2011: knee replacements, PCTA or stents, and MRIs. Each bar in each separate graph represents a hospital in that service area, the geographical areas where supposedly relative value units were used to standardize payments. However, as you can see, there was a wide variety of prices for each procedure within each market area. The most significant gap occurred in Columbus, Ohio, where MRIs were priced over 6 times higher in the most expensive hospital compared to the least expensive. So while good in theory, the assignment of relative value units did not, in practice, tend to equalize prices. As you can imagine, one problem with fee-for-service reimbursement is that it tends to reward volume of services without emphasis on quality. Another problem which Medicare attempted to fix in 1989 and again in 1992 and 1997 was how to project forward to determine prices for the next several years going forward. For several years, the actual spending per beneficiary outpaced the projected medical expense index, as you see here. The top line is the actual spending per beneficiary. and it way outpaced the projected fees to be paid to doctors. So in 1997, the CMS, Centers for Medicare and Medicaid Services, initiated the Sustainable Growth Rate, and that's the SGR, based on previous year's expenditures for Medicare Part B and projecting ahead based on inflation. This was a method to ensure that the yearly increase in expense per Medicare beneficiary did not exceed growth in the gross domestic product. Based on this rate, physicians were supposed to be reimbursed enough to keep up with inflation. However, in the early 2000s, the sustainable growth rate began to fail, and payments allocated to physicians were falling. According to an article in the Journal of the American Medical Associations, Medicare costs were driven by physicians simply doing more and more. Medicare growth became even more all about volume. Yet, the sustainable growth rate addresses only price, which perversely makes incentives to expand volume, which then trigger additional SGR mandated cuts, and then pressures physicians to further expand volume. Quality was not at all part of this incentive system, and it was growing out of control. In the early 2000s, Congress was worried that, cuts would drive physicians out of Medicare and started postponing them, that is, cuts to what they reimburse physicians. This was the first of many patches known as the Doc Fix. They were implemented each year to increase payments to physicians. In essence, the payments to physicians were increased by borrowing money from the future payments for physicians from that future fund. Each year, the president had the option of discontinuing the Doc Fix, but through 3 presidents it didn't happen. So each year the amount that payments should be cut mounted until in 2015 it would have meant a 24% cut in physician reimbursement on average. And this is just a graphic illustration of Medicare payment prior to the macro law of 2015, which we'll be talking about next. MACRA 2015. Now this is something you don't see every day. That's John Boehner, the former Speaker of the House, and House Minority Leader Nancy Pelosi congratulating each other on the passage of MACRA, the Medicare Access and Chip Reauthorization Act of 2015. MACRA changes the way that Medicare rewards or will reward clinicians for providing quality care by streamlining multiple quality programs into a new quality payment program tied to Part B fee-for-service payments. Beginning in 2019, but ramping up now, alternative payment methods are designed to replace the sustainable growth rate, and the Doc Fix will be instated. Under MACRA, what was called the Quality Payment Program was begun, and this is Medicare still fee-for-service, but actually the payments, in addition to being fee-for-service, they're tied to quality or value through alternative payment models, and this starts at the end of this year, and the goal is to have 85% of these in place by the end of 2016, and then 90% by the end of 2018. And these are value-based payments, and we'll talk about what that means in a minute. And these next few slides are taken from a webinar put on by CMS actually today. I was waiting for this to come out because it has a lot of the updates on how this program is going to work. But it repeals the sustainable growth rate formula, and then it takes several different quality reporting programs and combines them into merit-based incentive payment systems and advanced alternative payment models, and these are all based on quality and on electronic health records. And what the plan is to combine quality measures, analysis of resource use, that is costs, and then clinical practice improvement measures, and finally a really good, more than just electronic health records. We'll talk about what more it is, but it's advanced. They call it advancing care information for clinicians. Initially, only physicians were going to be able to participate in MIPS, but that has recently been redefined to include other clinicians such as dentists, physician assistants, nurse practitioners, nurse anesthetists, and then after another couple of years there will be other health professions that will be included, but that hasn't been decided yet. I think it depends on the success of the first 2 years. It's important to note here too that most clinicians eventually will be subject to the merit-based incentive payment systems, whether they're in an advanced alternative payment method or not. But this will phase in over time so that almost everybody will be, whether you are practicing as an individual or as part of a group. And there are a lot of technical details about that I won't be going into, but the way that they will put people into the program is through their unique tax number. And then at some point, it will not only be groups that practice in the same physical location, but what they call virtual groups. But that's not going to be in the first couple of years. So they're trying to cast as wide a net as possible, but it may be some time before they can implement virtual groups. One other thing to note here before going any farther is that this MIPS does not apply for hospitals or facilities. It's simply a way of reimbursing clinicians, not the facility, not the hospital. And there are 3 groups of clinicians that aren't going to be part of the MIPS, and that is people that are in the first year providing services under Medicare Part B, because that gives them a chance to get their volume established. And then also people who have low patient volume below a certain threshold, because it's very hard to calculate average payments based on low volume. And then people who are in other advanced alternative payment models other than MIPS. And you can see here that if you bill less than $10,000 per year or see less than 100 patients per year, then you cannot participate in MIPS, or you're not eligible to. And these are the categories that are going to be used to assess people's performance for reimbursement. You can see that in the first year, a full 50% of it is based on quality measures, and then another 15% is based on clinical practice improvement activities, and these are things like improving patient safety and outreach. Cost, only 10%, and then advancing care information, which is the health information systems piece that we talked about before, will account for 25% of it. So it's already going to be basing payments 50% on quality. Now this is a proposed rule, and what I'm going to do is put this as part of your handouts for this week because it's kind of small to see on this slide, but this is the categories for scoring performance. And the good thing about this is that the clinicians themselves will choose 6 measures that they want to report that best reflect their practice. So it's going to be different by specialty. It can be flexible by specialty. And they go into more detail here. And then they will report interoperability of information exchange, and they get to pick those 2. Clinical practice improvement, and you get full credit for this one if you are operating a patient-centered medical home. And finally, cost based on claims data. Another thing that the MIPS system does is change quality reporting. And prior to MACRA, there were 3 different streams of reporting for Medicare clinicians. The PQRS, and that's a whole data set of outcome measures that physicians are supposed to report on. Value-based payment modifier, which was a multiplier developed by Medicare. Excuse me, and then their incentive program for using electronic health records. These will all be merged. And the objectives for information systems are much broader under their proposed rule for what they called advancing care information. First of all, the HIPAA is absolutely retained, protecting patient health records. Electronic prescribing, e-prescribing, electronic access for patients to their records, and then coordination of care through engaging patients electronically, a health information exchange, and then clinical data registry reporting, which will be required next year, I believe. And now we get to the bottom line. So how are eligible clinicians reimbursed based on their performance under MIPS? Well, as before, we talked about the 4 components: quality, resource use, clinical practice improvement activities, and advancing care information. All of these are added up and scored. I won't go into the detail, but they add up to a score of 100. And then performance threshold is decided upon for each clinician or each clinician group. And if their composite performance score is above the threshold, they will receive more. If it's below the threshold, they will receive less. So you see here that if the performance is below the threshold, equal to 25% of the threshold, will yield a maximum negative adjustment of 4%. Likewise, if it's above, they will receive a positive reinforcement of up to 12%, depending on how high it is above the threshold. And then they can have additional bonuses if they have exceptional performance. So conceivably, clinicians could make a lot of money depending on how well they perform on these different composite scores. And this is supposed to be more palatable to clinicians because they themselves are going to be the ones to determine which measures will be used for their performance, their individual performance, or for the performance of their clinic. And although this is a proposed rule, which means that it is on the CMS website, and you can research more information about it if you're interested, and you can actually make public comment, but they're hoping to implement it pretty soon, starting in January of 2017 for the first year. And then the feedback report for that first year would be in July. More reporting and data collection until finally in 2019, the adjustments for that 2-year period will begin to take effect. So adjustments in payment will begin to take effect in 2019. And there are many other components of the merit-based incentive payment systems, and there are other types of advanced alternative payment systems that I could go into, but I don't want to go into detail on each of these. But patient-centered medical home is also one of the permutations. And this slide shows what Medicare is going to do to support small practices who want to begin using the MIPS this year. About $20 million a year for technical assistance, and that was the same thing. They did provide technical assistance for coming to meaningful use a few years ago, but now $20 million for technical assistance to develop those criteria and to transition to an alternative payment method. And then there's going to be an advisory committee comprised of clinicians to help promote their development of the physician-focused payment models. And these are the payment models that we've been talking about here that are based on those 4 criteria. So that's kind of MACRA in a nutshell, and it's an ongoing law that is in the implementation stages, so a lot of changes can be made over the next year. If you're really into health policy and management, or if you're in the health administration track, it's something that you will want to keep tabs on, and I will put up a couple of URLs for you to research this further.